Welcome back to the Society for Pediatric Pain Medicine's Visual Pearl series. This is part 2 of diagnosing hypermobile Ehlers-Danlos syndrome. In 2017, the international classification was redesigned to improve diagnosis. But new research has shown that our patients do not always fit the classic criteria. Let's review the 3 criteria. Criterion 1 focuses on generalized joint hypermobility, or GJH. Generalized joint hypermobility is the foundational requirement for an hEDS diagnosis, reflects systemic connective tissue laxity, and distinguishes it from isolated flexibility. The Beighton Score, described in the previous video, is one part of Criterion 1. An in-depth history with a standard questionnaire is critical to identify prior hypermobility. A detailed review of both the scoring system and questionnaire is covered in Part 1 of this series. There are 3 main criteria used to make the diagnoses of hypermobile Ehlers-Danlos. Criterion 1 establishes generalized joint hypermobility. Criterion 2 captures the broader clinical context, including systemic features, family history, and musculoskeletal complications. Criterion 3 ensures that other diagnoses are considered and excluded. The Beighton Score assesses a patient's ability to perform a series of well-defined maneuvers and is age-adjusted to account for the natural changes that occur in connective tissue flexibility over time. If a patient scores 1 point below the cutoff, the historical hypermobility questionnaire is used to capture prior joint laxity that may no longer be present on exam. Together, these tools help ensure that Criterion 1 accurately identifies generalized hypermobility rather than isolated flexibility. Criterion 2 evaluates the broader clinical picture and is organized into 3 categories. Feature A focuses on systemic manifestations of a connective tissue disorder. Feature B captures a relevant family history consistent with the current diagnostic criteria. Feature C addresses musculoskeletal complications, including chronic pain or joint instability. To meet Criterion 2, a patient must satisfy at least 2 of these 3 features, ensuring that the diagnosis reflects multi-system involvement rather than joint findings alone. Feature A focuses on systemic manifestations of a generalized connective tissue disorder. To meet Feature A patient must demonstrate at least 5 of 12 defined clinical features spanning the skin, musculoskeletal, cranial, facial, and cardiovascular systems. Importantly, these features may evolve over time, with some becoming more apparent with age, while others may lessen or change in presentation. This underscores the importance of longitudinal assessment rather than a single point-in-time evaluation. Feature B focuses on family history and supports the hereditary nature of hypermobile Ehlers-Danlos syndrome. To meet Feature B, a first-degree relative must independently meet the current hEDS diagnostic criteria as defined by the 2017 International Classification. Prior diagnoses made under older or less stringent criteria are not sufficient. This feature strengthens diagnostic confidence by confirming a consistent hereditary pattern. Feature C captures the musculoskeletal complications associated with hypermobile Ehlers-Danlos syndrome. This feature is met by the presence of chronic musculoskeletal pain lasting 3 months or longer, widespread pain for at least 3 months, or recurrent joint dislocations or frank joint instability occurring in the absence of significant trauma. These findings reflect the functional impact of connective tissue laxity and are central to understanding symptom burden and daily challenges in affected patients. Criterion 3 serves as the diagnostic safeguard. Its purpose is to ensure that a patient's findings are not better explained by another condition. This criterion requires no unusual skin fragility, which helps distinguish hypermobile Ehlers-Danlos syndrome from other EDS subtypes. In addition, clinicians must exclude other heritable connective tissue disorders, as well as rule out neuromuscular and genetic conditions that can present with joint hypermobility, weakness, or pain. This step protects patients by preventing missed or misclassified diagnoses and ensures that hEDS remains a diagnosis of both inclusion and careful exclusion. Patients who do not fully meet the diagnostic criteria for hypermobile Ehlers-Danlos syndrome may be diagnosed with a hypermobility spectrum disorder, or HSD. HSD is not a lesser diagnosis. Many individuals with HSD experience a symptom burden and degree of functional impairment comparable to those with a formal hEDS diagnosis. Regardless of the specific diagnosis, these conditions are clinically significant and warrant the same thoughtful, patient-centered approach to care. When evaluating children and adolescents, there are several specific considerations. Joint hypermobility is more common in younger patients and often decreases with age, making age-adjusted interpretation critical. Many systemic features evolve over time, so children may not initially meet full diagnostic criteria. The focus of diagnosis and treatment should be on minimizing and improving the functional impact of this disease. This includes managing pain, fatigue, school participation, and physical activity. Careful longitudinal follow-up allows clinicians to support patients early. An accurate diagnosis helps guide patient and family expectations, supports clear and informed counseling, and provides a framework for long-term planning. Diagnosis also facilitates multidisciplinary care, allowing coordination among primary care, pain psychology, pain management, physical therapy, and other relevant subspecialties. Pain management strategies in these patients should be multidisciplinary, individualized, and focus on functional restoration. Thank you for joining us for this visual pearl on the diagnosis of hypermobile Ehlers-Danlos syndrome. We invite you to watch the next visual pearl in this series as we continue exploring practical, evidence-based topics in pediatric pain medicine. If you're not already a member, we also encourage you to join the Society of Pediatric Pain Medicine and be part of a growing community dedicated to education, collaboration, and improving care for children with pain.